Arguably, pregnancy's biggest mystery is preterm birth. Why do women go into labor early and without warning? Why does a seemingly healthy young woman with no risk factors deliver a baby at 24, 28, or 32 weeks? Why? This question is probably the key question March of Dimes scientists around the world have been trying to answer for years. And not just them. Scientists from all types of institutions have been nagging at the same question to little avail. But this year, there was a crack in the case. Scientists from the March of Dimes Prematurity Research Center at the University of California, San Francisco, or UCSF, published a paper with an extraordinary finding, a clue about why spontaneous preterm birth is so hard to explain, and a blueprint for how to begin to unravel its secrets. The paper's findings represent a fresh start. After decades of little progress on the question of spontaneous preterm birth, things may finally be starting to fall into place. And I've got two of the key investigators behind the effort right here to explain the news. This episode is about spontaneous preterm birth. Stay with us. Dr. Tony Capra is an epidemiology and biostatistics professor at the University of California, San Francisco, and Dr. Marina Sirota is a professor in the Department of Pediatrics at the same university, UCSF, and the acting director of the Baker Computational Health Sciences Institute at the university. Tony, it's your first time here. Welcome.
Thanks. So happy to be here.
Marina, welcome back. It's your second time.
Thank you so much.
It's a real pleasure to have you both here to talk about this very vital topic. So let's begin. I mentioned at the beginning that we know very little about spontaneous preterm birth, but that your paper, published this year in the journal BMC Pregnancy and Childbirth, detailed a big discovery about why we know so little about it. So I just want to say to anybody listening, you did not crack the case of spontaneous preterm birth and why it happens, but you cracked a very important beginning piece of the puzzle, which is why is it so mysterious? We have to understand why this thing is such a mystery before we can solve that mystery. And so that finding is that spontaneous or unplanned preterm birth is fundamentally different from indicated preterm birth. Indicated preterm birth occurs as a result of doctor-recommended induction because doctors decide it's safer for the baby to be out of the womb than in. Spontaneous happens without warning. Everything's going well, and all of a sudden, the woman goes into labor. No indicators as to why, no reasons. Apparently, a healthy pregnancy is reaching an end. Your analysis of electronic health record data found that spontaneous preterm birth shares no diagnostic risk factors in common with indicated preterm birth. So no risk factors in common. This means that preconception risk factors of women who end up having an indicated preterm birth, for example, diabetes, are not more common in individuals who go on to have spontaneous preterm birth than term births. Moreover, no conditions were risk factors for spontaneous preterm birth. So essentially, your analysis found no early warning signs for spontaneous preterm birth, and none of them were shared with indicated preterm birth. And so, in other words, the finding is that spontaneous preterm birth is a complete enigma. Some listeners might ask why this discovery is a good thing. Well, it's a very good thing because before you can try to solve a problem, you need to understand it fully and understand the complete challenge of it. And by discovering that this phenomenon stands completely alone, you can start looking in the right places. That's fundamental to solving the mystery because we're finally looking at the right map. So now we can get to our destination. Tony, Marina, tell me why this is important. Maybe Tony, will start with you.
Yeah, I think this is so important because prior to this study, we and many other groups had, out of necessity, given the data available, had to study spontaneous and indicated preterm birth together. And so we knew many risk factors and many associations, but we weren't sure which ones really applied to those spontaneous cases, which are often the most potentially dangerous and unexpected. And so, just as you said, this gives us a new way to understand what's similar and, more importantly, as we've seen, what's different about the two different pathways to preterm birth.
Marina?
Yeah, I mean, I'll second everything that Tony said and also say for some molecular studies, we've been able to identify smaller specific cohorts and focus on women who might have had a clinically indicated preterm birth or went into labor spontaneously. But large scale data sets are much more difficult to curate systematically. Here, we're leveraging electronic medical records, which is data that comes from going to visit a doctor, whether it's clinical notes, diagnosis codes, which are used for billing, medications, lab test results. Here we focus on diagnoses, but we're able to leverage this large data set to ask this specific question in a more global way than previous studies.
Yeah. And so, how similar did you think spontaneous and indicated preterm births were? And that's a question for you, Tony. I mean, I'm guessing you thought and knew that they were different, but you probably thought there were. Did you think that there were some similarities in common?
Yeah, we really didn't know for sure either way. Preterm birth we know is very heterogeneous. There are many, many pathways to end up delivering preterm. And to be honest, I had always assumed that the spontaneous preterm births were driven, at least in part, by risk factors that we already knew, but just hadn't caught or were just below sort of diagnostic thresholds. But these results, which we obtained by having big clinically curated cohorts of spontaneous and indicated preterm births, enabled us to see that those risk factors like hypertension and diabetes that we know are main drivers for indicated preterm births just were not statistically more likely in the spontaneous preterm births. So I was wrong. um,
You mentioned just now, Tony, that you initially thought that maybe these, for example, hypertension and diabetes were below the diagnostic
mhm.
thresholds. Isn't it still possible that that's the case because your analysis of EMRs was based on diagnoses, right? So, or diagnosis. So, isn't it possible that maybe a woman was just about to get diagnosed with, would have been diagnosed with diabetes 2 weeks after that EMR
It,
record was written or something like that?
it
Are
certainly
we
is
ruling that
possible.
out? Okay.
Yeah, it certainly is possible. But the diagnoses we're looking at here occurred sort of independently and before the pregnancy. So
Mm,
they were based on different criteria than may have
okay.
been used in the analysis during pregnancy. But absolutely, it's possible that we still could have an issue of there being some thresholds here or combinations of risk factors. And we'll talk about that
Right.
a little bit more in the future work that I think would be really interesting to investigate. And to put a positive spin on this, I think it is indicating that we are doing a quite good job of identifying individuals with these risk factors and putting them on the pathway to indicated preterm birth.
Yes.
So I think that is positive, but it also just underscores the enigma of this other cohort of spontaneous preterm births.
Yeah, absolutely. And as I mentioned earlier, this finding that they are completely different was made possible because you were able to separate them from within the data analysis. You've got, instead of spontaneous and indicated in one big bundle of data, you were able to separate and kind of look at them as two different groups. This was absolutely critical to the analysis. Marina, why has this, and Tony talked a little bit about this in the beginning, but why has this not been done before? Why have scientists not been able to look at these two groups separately prior to this paper and this cohort?
So again, I think they were able to look at these groups separately in a smaller scale. So if somebody is recruiting patients for a study for, let's say, 20 patients, 50 patients, 100 patients for a specific study, they could still recruit by these criteria. But what we were using here is electronic medical records data broadly from the UCSF population. And we started out really broad. We started with over 46,000 deliveries. And then the curation happens, figuring out what exactly are the criteria of the women that we want to explore and look at. And at UCSF, we have a phenomenal resource. It's called the Perinatal Database, which, in addition to the overall clinical record, this is a data repository that's being maintained by the OBGYN department, where every single birth is curated by clinical fellows and clinicians to capture some of these outcomes. And we're very lucky because spontaneous versus indicated preterm birth is one of those things that is being captured routinely in this hand curated repository. We're not quite able to glean that out of the medical record more broadly, at least for now, though we are thinking of ways to expand that and apply more elaborate predictive models or AI to the data to be able to do this now across other institutions as well. But to enable this study, it was because we had access not only to the clinical records, the identified clinical records for research purposes, but also this curated perinatal database that allowed us to map between the two resources and say, this is a group of women who delivered spontaneously preterm birth, preterm, and this is a group of women who delivered preterm through a clinically indicated scenario.
Tony, this may be a silly question, but I'm wondering why even study indicated preterm birth if the reason for the indication is clear and made available on the EMRs, right? For example, indication as a result of preeclampsia risk or existing preeclampsia or gestational diabetes or hypertension or not enough movement inside the belly. I forget
Yeah,
what they call that, but low
it's
fetal
not a
movement.
it's not a silly question at all. We really had two main reasons for including the indicated preterm births explicitly in the study as well. The first was just to see how those guidelines were playing out in a real world cohort. Did we see the expected risk factors coming up as the major associations? And then also, it's
What was the
possible there
answer
might
to
be.
that question, Tony? What was the answer to
Yes,
that?
yes, we did.
We did. Okay.
Yes, absolutely. Diabetes and hypertension were our two strongest risk factors by far, which is reassuring. But we did also find a range of other comorbidities, I can talk a little bit more about later, that may also suggest additional risk factors or potentially more complexity in the way that we should think about the drivers of indicated preterm birth. But also for our particular purposes in this study, it provided us with a baseline or reference point for seeing how the associations and risk factors for spontaneous preterm birth would compare to those that we already know. So I think it's not a silly question at all, and but it was a really important part of our study.
Marina, tell me about the study design. How many births were involved in this analysis? When did they happen? How many spontaneous, how many indicated, and what was the time frame studied?
Yeah, happy to dive into that. So I mentioned a little bit earlier, we actually started with a huge data set. And I'll comment on the fact that, you know, data from the electronic medical record provides an incredible opportunity to ask questions and do research, but it's also incredibly messy. It's not the type of data that's collected for research purposes, it's collected for billing. So we started with over 46,000 deliveries at UCSF from 2001 to 2022. And then there's a number of missing data where we don't have gestational age at delivery or maternal age. There are some conflicting records. We wanted to focus on singletons. And in many, actually, in a large set, about 29,000 of the pregnancies, we didn't have any diagnosis codes prior to the pregnancy. And this study really focused on looking at comorbidities or diagnoses that happened prior to the woman getting pregnant. And this is understandable. UCSF is a tertiary center. We have a lot of referrals, especially for difficult pregnancy cases. So women a lot of times get referred when they're pregnant already. And for those women, if we didn't see them prior to conception, we wouldn't have the diagnosis codes to ask this question. So once we have a funnel and we narrow down, we had about 10,000 singleton deliveries. About 1,000 of them were preterm, defined under 37 weeks of gestation, and about 9,600 were term deliveries. And then when we split those 973 into indicated and spontaneous, they were about half and half. So you can see how starting out with a huge number, when we have a focused question, we actually go down in sample size quite a bit.
And Marina, forgive me if you already mentioned this, but out of the preterm group, preterm birth group 970, whatever, in terms of spontaneous and indicated, what was the average gestational week for indicated and spontaneous?
Oh, listen, that's a great question. Unfortunately, I don't have the exact numbers at the top of my head, but from what I recall, looking at the comparison of the overall gestational age distribution in our indicated versus spontaneous cases, I don't recall there being a significant difference.
Okay. And Marina, another thing that you said was that this analysis was based on preconception EMR. Why the preconception instead of the prenatal
So
diagnosis?
I think an interesting question, it's very interesting to look at both. Um, in this case, as a first look, we decided to look at diagnoses prior to conception,
Okay.
but it is absolutely interesting. That will also increase our sample size, is to look at diagnoses during pregnancy across time. And that's something that we're actively looking into now.
All right, so Tony, we've been talking about how we didn't find any real risk factors in the spontaneous group, but let's talk about the indicated group. What
Right.
were some of the associations found between in the indicated group when we're looking at preconception health histories?
Yeah, no, so we were really reassured to see that by far the strongest associations with indicated preterm birth were with the well-established risk factors that align with clinical guidelines for things like essential hypertension, type 1 and type 2 diabetes. These had very high odds ratios, between like 6 and 12. And so that was good. We saw what we should be seeing in an indicated cohort. However, after hypertension and diabetes, we found a number of other associations. The next strongest was a set of kidney disease diagnoses, such as chronic kidney disease and other markers of kidney dysfunction, that does actually align with a substantial bit of literature that was already out there from both clinical and molecular studies. So that just adds further support to the relevance of kidney dysfunction. And then beyond that, we also found associations with lung, liver, and gastrointestinal dysfunction.
Hmm.
And these, I think, warrant more follow up. And we're sort of eager to see if these represent novel risk factors or novel pathways relevant to risk for preterm birth, or if rather they're more just side effects of the known drivers that we're already considering.
Yeah. And for those, Tony, as well as the kidney conditions, were those the result? Were those the reason that the indication happened, or they were just risk factors that you found once looking at the EMRs? Like, did the doctor say, kidneys don't look good, indication happening, or that it just said, some vitals are off, we're going forward with cesarean or whatever, and then you looked back and you said, hey, look, there's a red flag here with kidneys.
Yeah, we don't have the resolution to say for sure that for
Okay.
example, the kidney did or
Yeah.
did not contribute to that indication.
Hmm.
In most cases, I suspect not directly, but we can't say for an individual case if that was
Yeah.
true.
Yeah.
Um, but
What?
these
Yeah.
were, in the cohort as a whole, much more common than in the term cohort.
Understood. And in terms of the indicated preterm births, what do these EMRs say? Like, do they say indication as a result of, or what is the reason for the indication in the EMRs, or does it just say indicated and that's all you know?
So the electronic health record itself
Yeah.
doesn't tell us this. It's this other resource that we have here at UCSF, the perinatal database, that's curated by the clinicians that gives us that information.
Okay.
And so actually, Marina, I don't think the annotation is usually that specific, but you've worked with it more than I have, so I want to be sure.
Yeah, I don't think we know the reason for the indication. Um, it's something
Uh,
that, you can imagine doing the analysis of the codes during pregnancy too, and
Mm-hmm.
seeing what leads up to the indication and
Mm.
seeing if it matches the preconception diagnoses. So
Mm-hmm.
I
Mm-hmm.
think it's a great question, a possible extension, but it's not something that we can definitively talk about right now, I would say.
Yeah.
right, because
Yeah.
the data fields that we sort of have access to do not
Yeah.
provide that level of specificity.
Right, right. So many future avenues with this work, though, aren't there? Tony, another question for you. The exciting part of the study came when you ran statistical models on the spontaneous preterm birth group. Curious whether their medical histories would give clues about their birth outcomes. We've obviously, let the rabbit out of the hat. They did not give clues to their birth outcomes, but you were not sure, and this was an exciting part of the study. Um, but that did not happen, like I just said, that didn't happen. So tell me what you saw. What were those moments like for you? Was this kind of just looking at a computer and saying, what? Did you all kind of gather around a computer screen and say, no way? Or tell me about that, because I interviewed the Nobel Prize winners, the microRNA Nobel Prize winners, on the show a couple of months ago, and they actually looked at their sequences that matched separately, and then they said, let's talk in a couple hours, and they picked up the
Mm.
phone and they kind of had their aha moment together on the phone, being like, oh my God. And it was this eureka moment for the both of them. And what was that moment like for you two and the rest of your team with this
Yeah, yeah.
paper?
I don't think we were quite Nobel Prize level yet, but we were in the room actually that Marina is sitting in right now,
That is
and
very true. We were in
the
this very room.
the two of us and our the two lead first authors were looking at the plots, and the one for spontaneous preterm birth was just absolutely flat. There was no signal, nothing that was even really suggestive of an association. And of course, I thought, let's double check, let's make sure that there's not some bug or we haven't left out some data. And so, after a couple of rounds of back and forth and checking things, we saw that really no, there was nothing there. And it was one of those moments where at first you're a little bit disappointed, but then you realize this is actually incredibly exciting and interesting, and means we've got so much more to learn and so much more to work with.
Did you consider at any point, not like at the very beginning, did you consider, oh, maybe we don't even do a paper on this? The line, the curve is flat. There's no curve. And then you realize, no, wait, this is the paper. This is the finding. The
Yeah,
finding is that there's nothing
that's
there.
that's exactly the trajectory we went through.
Yeah.
Was realizing that this was actually far more interesting than if we had seen, a muted version of the indicated risk factors for the spontaneous.
Yeah, and I would say to add to that, I think the experience was also interesting for our trainees because at first they thought, "Oh, wow, I didn't find anything. What's wrong?" Or "What do we do? This is might not be interesting enough." But as we, continued to first, try to break what we see, that's what we always try to do computationally, and then started having discussions when we presented this work at the site visit to Dr. Selly. There's actually a lot of excitement. We were somewhat excited, but having other folks around the table get excited about a negative finding, that doesn't happen very often. And to us, it basically said that spontaneous preterm birth is incredibly heterogeneous. And it may be that we don't have the sample size, maybe 500 is not enough. Or maybe there's just different things going on in these women, um, and we need to look into it further and understand what's going on. And I think it was a good experience for us scientifically, but also for the students and postdocs who were leading the work and the analysis of how something that might look like a negative finding could actually be quite impactful overall.
Absolutely, and this might be obvious, but it also speaks to truth in science, right? You are not going to change your results. You are not going to, like you said, you tried to break it down to see if it was still accurate. But that was the finding. That was the truth of the moment, and that's what you go with. And that there's a certain indisputable objectivity in that, and that's why we're all here, because we believe in the truth, right? No matter if it's sexy in the moment or not, it does get you somewhere.
And we always try to set up our studies so that when we ask a question, the answer is interesting either way it turns out, if it's yes or
Right.
if it's no. And so I think this is a great example of how that surprising no can actually be you know really really generative and in the end very positive.
Yeah, absolutely. All right. So, Marina, I've got another question for you. I want to talk a little bit about the risk factors in the spontaneous preterm birth group. We have been talking for the last 30 minutes about how there were no risk factors, but I'm wondering about the information you do have about this group in their EHRs. Um, uh, I've learned as a result of my employment here at the company and at the organization and doing this podcast and working with, fantastic researchers like yourselves, that the and Marina, I know that you're working on this topic, is the vaginal microbiome, a massive cause of preterm birth. Maybe something like the bad bacteria inside the vaginal microbiome potentially could account for something like 40% of spontaneous preterm birth. This is what I've heard from our friends at Imperial PRC. And also we know that the bad bacteria inside the vaginal microbiome not only can be responsible for a large chunk of spontaneous preterm birth, but also HPV, human papillomavirus, as well as BV, bacterial vaginosis. Also related there, I think, are abnormal pap results. So, do we know about this group, whether this spontaneous preterm birth group, whether they had positive HPV, abnormal pap, bacterial vaginosis? Because then we could potentially say that vaginal microbiome might be a factor with this group.
This is a great question. So we did not look into a hypothesis driven question with respect to these individuals. But what you bring up is a really interesting extension of this work potentially. You know, in the past, I think one of our previous podcasts together was about leveraging publicly available microbiome data to build machine learning to predict which women are at a higher risk for preterm birth. And we were, fairly successful in that regard. Now here we don't know. Some of those might have been clinically indicated births. Some of them might have been spontaneous. I think we wanted to focus on spontaneous, but again, we're using public data. We don't always have that annotation. What you can imagine doing with the electronic medical records data is something similar, building predictive models and then bringing the two together in exactly the way that you discuss. So I can't say for this cohort of 449 women who delivered spontaneously preterm, we could go back and look, are there specific conditions or lab test results that are different for this group in a hypothesis driven way and tie that to maybe some of the associations that we found or predictive factors that we found or the Imperial group has found with respect to the microbiome. But we haven't done that yet. I feel like that's the next step, which would allow to bring the knowledge that we gain here from this EHR data analysis together with some of the other findings across the PRCs, let's say in the vaginal microbiome space, and see if we can bring them together into a single story.
Yeah, and Marina and Tony, you've both mentioned during this recording the various, new paths that we can take with this paper alone. You guys are working on, dozens of other papers and, other inquiries. And so I think it just speaks to the need for, more scientific research. And I'm glad that we're funding you guys and that your universities are funding you. Tony, I want to ask you about blood sugar and obesity. You did mention that the two leading factors for the indicated group were hypertension and diabetes. Did you have any information about blood sugar in the in the group for indicated? Because there was a paper that came out of the Stanford PRC that showed a very high, much higher, an increased risk of preterm birth for women whose blood sugar levels were just below the diagnosis threshold. So they wouldn't have raised any flags
Right.
with doctors, yet they went on to have a much higher risk with preterm birth. So I'm wondering, do we know anything about blood sugar? And can you talk to me about that a little bit?
Yeah, so as we were talking about earlier, here we've used the sort of diagnosis for having, um, diabetes or hypertension here. But in many cases, we actually do have lab values for these individuals that we could use to refine, that kind of binary classification. And I think that sort of analysis is best done in the way that Marina was talking about, where we have a hypothesis to guide us. And absolutely, the results from Stanford are really, really fascinating. And I would really love to look at those sort of in both cohorts and see whether perhaps we do get a little bit more signal in the spontaneous cohort when looking at the actual lab values. So, and as a hint about that, even though the results and associations were nowhere near significant, there were slightly elevated rates of diabetes in um, the spontaneous group.
Yeah. Okay, good. So now we've talked a lot about the future of this paper, this cohort. Like Marina said, you know, not bigger cohort than you've had before, but not the biggest cohort in the world, but still a gold mine of information. Special cohort. These women and babies may be holding the answers to the mystery of spontaneous preterm birth. You submitted the paper over a year ago. There's been 12 months of potentially new research. Have you? Do you guys have anything new to report that you found from this group?
Yeah, one of the things we're really excited about is moving beyond this, one diagnosis at a time framework. And a theme that's come up a few times here is the heterogeneity of preterm birth, and we think especially spontaneous preterm birth. So one of the approaches we're taking to that is to looking at that cohort, but instead of just saying one code at a time or one diagnosis at a time, what do they have? Can we identify more consistent patterns among sets of codes that vary together in one group versus another group that may then help us refine the kind of categories or hypotheses we test about the pathways into preterm birth? And we're seeing some really promising results on that there is that kind of structure in the spontaneous cohort, and that it may indeed have some associations with molecular characteristics. The exact details are still, still cooking, but that's one of the places I'm most excited to go next, is just to try to understand the heterogeneity using the full diversity of what's captured in the electronic health record.
Tony, could you give an example of kind of the clumping together of these codes that you're doing to create these different categories, so that
Yeah,
we?
I mean, so just as one example, in um, the indicated cohort, we found several different kidney related conditions or diagnoses that each individually had an association with the phenotype. But if you put them together, you see that there's a set of individuals that have some severe dysfunction in their kidneys, and you can get even stronger signal if you put them together. But this approach actually gets even more powerful when you move beyond just one system and start looking for patterns across systems that can help to indicate like what sort of dysfunction is occurring in that individual, and whether it really is specific to, just sort of trauma in one dimension, or if it's a more systemic issue.
Yeah, because it's all connected.
Mhm.
um, Marina, and so, Tony just talked a little bit about the future. I understand that future analysis includes laboratory data and clinical notes, that those will be included in the next round of analysis. Can you tell me about that and any other next steps from your perspective, Marina?
Yeah, absolutely. So the longitudinal aspect is very interesting to me. So as I mentioned, broadening out, not only looking at preconception, but the diagnoses and other, I guess, other types of data that we can capture during the pregnancy itself and what we can glean from that. I think that will increase our sample size significantly. We are also starting to look into some hypothesis um, driven studies, not just data driven. What does the data tell us? So, for instance, another condition that we study pretty extensively in my own group is endometriosis. So, we're starting to look at what are the links between endometriosis and pregnancy outcomes like preterm birth, whether indicated or spontaneous. And we're starting to explore these type of kind of specific questions. Um, yeah, and I guess the other one that I would like to get into that we haven't gotten into yet is this idea that we can use the mapping and the annotation for indicated and spontaneous that we've developed, that we have, through this curated perinatal database here at UCSF, and see if we can leverage that to build a model to predict spontaneous and indicated versus indicated preterm birth, and then collaborate with, let's say, our Stanford colleagues who we work with very closely to see if any of the associations, maybe by pulling data across our two institutions, or the other resource that we have access to is clinical data across the UC system, and see if we maybe can identify clinical factors that are associated with spontaneous preterm birth. Once we know that we can distinguish and identify spontaneous preterm birth cases, not only at UCSF where we have this resource, but at other institutions.
Yeah, that last piece is a big deal. Is to create, yeah, a spontaneous preterm birth prediction tool, and collaborate with Stanford. Well, that is all very big stuff. I hate to ask the question of when could we see all of this happen clinically, but I'm going to ask it anyway. Are we talking 5 years or 10 years or beyond?
So I guess clinically in terms of the prediction model or in terms
Well,
of what
maybe,
clinical
but
impact?
maybe at what point do you think that we could have a paper on the findings of what you just mentioned and Tony just mentioned, kind of when we can start pulling together a lot of these threads that we've been talking about, these unanswered questions? When do you think that we'd be in a better position than we are today?
Well, from my perspective, I think we're going to just take it one day at a time and see. And
Yeah.
hopefully, we'll continue to publish in this space, leveraging electronic medical records to answer questions about pregnancy. So I don't know, maybe one a year. We'll see how it goes.
Yeah, no, I totally agree that the thing about research is you never know what you're going to find, as this study illustrates really well. And so I'm optimistic that we will be able to do this sort of data integration that Marina's talking about, because her lab and my lab have lots of experience doing that kind of work. And so we know it's complicated, but we know it can be done. And we're really motivated to do it given just the incredible importance of this question. And so, I hope that next study will yield the really clear clinical impactful result, and we'll just have to see.
Yeah, absolutely. Tony, you mentioned that you were, that it's complicated, but you're hopeful.
Yeah.
Um, Marina, would you say the same thing? Because we talk about March of Dimes a lot about how, decade in and decade out, we still haven't solved preterm birth. We're really trying with our translational science kind of strategy to make an impact. And like Dr. Selly, our chief scientific advisor, says, in this lifetime, we want to do it in this lifetime. Um, are you hopeful, Marina?
Absolutely. I'm very hopeful. I think we're, across our whole center, we're trying to use or we're aiming to use data in different ways to help either predict women at a higher risk for preterm birth, but also come up with interventions. And I think we can get there. I mean, we have lots of avenues that we're exploring from different directions, whether it's drug repurposing, microbiome, electronic medical records, um, other multi-omics approaches. I think if we take this kind of multi-pronged approach to studying preterm birth, I'm hoping we can make an impact in our lifetime. That's what we're striving to do.
Yeah, absolutely. And I think the heterogeneity of preterm birth that we've been talking about really necessitates that kind of approach that Marina's describing. And it also is an opportunity. I anticipate that there will be certain forms that we really will be able to hopefully very soon have an impact on, and others that may be much, much longer term challenges.
Yeah, absolutely. Well, certainly a hopeful discussion with the two of you, and a fantastic paper that answered a very important question. So thank you for this analysis, and thank you for your continued work on the vital question of spontaneous preterm birth, the biggest question probably in the field of maternal and fetal health. So I appreciate the two of you. Please come back when you have an update on the secrets of this cohort and any news that you have from the various avenues that you're pursuing. Thanks again for coming on the show.
Oh, it's our
Thanks so much,
pleasure. Thank
Alyssa.
you so much for
It
having
was fun.
us.